Okay, so good evening, everybody. Today we have this intersection course for the secondary IOL, and I need to welcome all our speakers, eminent speakers, starting from Dr. Amal Waraiqat from Jordan, and Professor Jorge from Spain, and me, Dr. Safwan Bayati, and Dr. Yasin Dawood from States, and Dr. Nancy Al-Raqad from Jordan. Hopefully that all of us there. And we will start with this instruction course, which has a lot of controversy and a lot of questions around it. We will start with one of the famous surgeons doing these secondary IOL implantation, Dr. Amal Waraiqat. So Dr. Amal, the microphone with you.
Thank you, Dr. Safwan, for this kind introduction. And it's an honor to be among this great group today to talk about one of my favorite subjects, actually, the Amani intrascleral fixation. So let's share the screen.
Yes.
Okay.
You have it on the desktop?
Yeah.
Yes. Okay. Yes.
Okay, so today I'm going to talk about the pearls and pitfalls in the Amani intrascleral haptic fixation. I have no financial disclosures. So if we have a posterior capsule rupture, the most important thing is do not panic and do not withdraw your phaco probe immediately. Do not leave any residual cortex in the anterior chamber. And if you are manipulating or working with a secondary IOL, there should be no vitreous in the anterior chamber. And at the end of the surgery, you should have a stable posterior chamber IOL in a desired and appropriate position. So if we have a small posterior capsule rupture, then the things are easy. We can implant a single piece or a 3-piece lens in the back and continue the rupture as a posterior capsulorhexis. But if we have a large PCR, then the things are different. We can use a 3-piece lens with a posterior optic capture. So implant the lens in the sulcus and push it behind the anterior capsule. Or if we have to use a single-piece lens, we can do the anterior optic capture, which means that the optic is anterior to the anterior capsule. If there is no sufficient capsular support, there are many options, and this includes the iris fixated lenses, and then the iris sutured IOLs, the scleral sutured, scleral fixated IOLs. This is one of the aniridia IOLs that is sutured to the sclera, and then the Amani intrascleral haptic fixation. So this is a diagram showing my technique and my approach to this procedure. Sometimes I use an AC maintainer and sometimes I don't. But the most important thing is to have a good pressure in the eye when you create your tunnels or when you pass the needle for the Amani. So before doing the first case on a true patient, always be ready. There are many transfer labs in the meetings, and then we have the surgery. This is one module, the Semel eye, where you can practice the procedure and it mimics the real situation. Get the right instruments. So I use the 30-gauge thin-walled needle for this procedure. Now, regarding the lenses that are available, we have the lenses, the haptic that is made out of PMMA. We have the MA60AC from Alcon. This is a 3-piece lens with an overall diameter of 13 millimeter. The optic diameter is 6 millimeter. The haptic is made out of PMMA. This is this thickness ZA9003. This is one of the lenses that I use very commonly, and I like this. And this is one of the lenses that is available in Jordan. The CT Lucia is not available in Jordan, and what is special about this lens, as we all know, is the haptic is made out of PVDF, so it resists kinking and the manipulations while doing the procedure. So this picture shows how the PVDF haptic is, it can resist the manipulations compared with the PMMA haptic. This is a lens that also is not available in my area, but I think it's one of the original lenses that were used by Dr. Amani. This is a 3-piece lens with an optic diameter of 7 millimeter, and that made this lens a special lens because it is more forgiving to decentration because of the big optic size. And also the haptics are made out of PVDF. Now moving to the pearls for this technique. I like always to do the marks before entering the eye, because once you do your paracentesis and dilate the pupil, the things are different. So it's very important that when you put your marks, you cross the central part of the pupil so that the lens will be in appropriate position. And as I mentioned, we should always have a good pressure in the eye when we start the procedure. So I do the main incision 90 degrees away from the 2 marks that are 180 degrees apart. I insert the 3-piece lens, and I keep the leading haptic resting on the iris inferiorly, or depending on the position where you enter the eye. I do this small trick. I put a mark at 2 millimeters from the tip of the needle. This will aid me or help me to change my direction, to know when to change my direction. When I enter the sclera, I reach the point, the mark, and then I change my direction toward the center of the eye. So this helps me a lot. And we use the opposite paracentesis. So the paracentesis can be done at 10 and 2 or at 9 and 3. It depends which position is more appropriate for your hand. And I use the intraocular forceps through the opposite paracentesis to dock the haptic into the lumen of the 30 gauge needle. Now I externalize the first haptic. I like to do this. Some people keep the lens with the needle, but I feel more safe doing it this way. Now I change my attention. I turn my attention to the trailing haptic, and we do the same procedure. I mark the needle, and then I use the tip of the 30 gauge needle to push the edge of the optic to put the lens in a more appropriate position for the docking technique. This step might be a little bit tricky, but with training and with doing more cases, it becomes, you know, a routine thing to do. So I engage
Dr. Amal, I just need to interrupt you here, because this step is very important to know by all the audience. Why we did a modification for this technique, because this step, it need, as you said, more experience to deal with it as a second. So the leading is easy, but the trailer is it need more technique, more experience.
Yeah.
Yes,
yeah, of course. Yeah. So actually, I always teach my fellows and my residents in this specific step. So when I dock the haptic into the lumen of the needle, I come from above so that the angle would be a little bit easier for me. And this is difficult, you know, to be given on an instructional course. You need to see the case exactly, see how easy it can go, but it needs experience.
Yeah, I think that Simul-I is the best to teach them. So Simul-I is the best.
Yeah, it's the best thing, you know, to do before starting your first case.
Yes.
And at the end of the surgery, I make sure that I had pushed the melted knobs inside the eye, so that when I see the patient the first day, I don't want any knobs that are exposed through the conjunctiva. Also, when we use a cautery, I always tend to avoid the high temp cautery. The high temp cautery tend to result in a significant loss of the length of the haptic. So we need to avoid this. Low temp cautery is much better. Now, sometimes, you know, I get a lot of referrals for those cases. Sometimes the lens is decentered, so I can do some trimming. I take the knob out, and sometimes I cut the haptic on one side, so that I will get a better centration of the lens. Always, it's important to remember, as I mentioned, to push the knobs of the sclera, of the lens inside the sclera. Each lens melts in a different way. So the CT Lucia lens, it gives the mushroom shape. The ZA9003, it gives a tapered shape. So it's much easier to bury in the sclera.
Yes.
Now,
another interruption, Dr. Amal, because these are important points. Now, why sometimes we are leaving the needles as a double needling? Because when we are externalize the haptics, the leading haptics first, and cauterizing it, when we are dealing with the trailer haptics, that haptics in the sclera, it might stretched.
yeah.
And that, in my opinion, is one of the points that might, in non-expert hand, can lead to a decentration or change in decentration, or later on dislocation from one side.
Yeah,
yes,
yeah. That's
Continue.
a very valuable point, right?
Yes.
I noticed this. So I did more than, I would say, 500 cases of Amani over the last 5 years, but I found this problem specifically in the MA60 AC lenses. It is weak at the optic haptic junction.
Exactly.
So this was one of my cases where we had the dislodgement at the optic haptic junction, and I had to cut this lens and take it out. Now, it's very important to cut the melted knob before taking the lens outside the eye, because this might be tricky, you know, to take it without having this area cut first. Sometimes we need to work, I'm an anterior segment surgeon, but we always need the help of the retina colleagues. So I do most of my cases without them, but sometimes you need a posterior segment surgeon to be with you.
Exactly.
Now, it's very important to be comfortable with vitrectomy, whether an anterior or a pars plana vitrectomy. You don't want to do a lot of manipulations in the eye, especially in high-risk eyes such as Marfan patients. So it's important to deal with the vitreous before doing anything else. Now, also, you can combine this procedure
now, here,
with other...
Dr. Amel, one of the important question here. Now, you said that you need the iris for... Sorry, Dr. Amel. Here, you said that you need the iris as a support for the leading haptics. Here, you don't have the support. So how you support yourself?
Yeah. So in this case, that was a case we worked with the retina team together. So when I saw the iris is fully, that is a case of traumatic mydriasis with aphakia, so I had to do the pupilloplasty in this case. As I did the pupilloplasty in the beginning, then I did the Amani intrascleral fixation.
Yeah. So that's why we are dealing with the modified, because here when you don't have the steps, when you don't have the support of the iris, the modified will gives you the two support for the leading haptics and the trailer haptics. Yes, Doctor. I'm sorry that I interrupt you, because this is an important point that it will be in our discussion. Yes, my dear.
Right, and you know, this is a very fruitful discussion, because
exactly,
you know, for if you are not doing this a lot, then you can't understand the value of those points. Those are very valuable points. One more thing I would like to add: I always leave the trailing haptic outside the eye. So if I don't have support, sometimes I use Helon I fill the AC with Helon, so that might give a little support if I don't have an iris support. But yeah, this is a very valuable point.
Yes.
Now, as next day, you will be amazed. The eye appears as if it is not touched. You know, I've been doing a lot of the scleral sutured IOLs, the iris sutured IOLs. In this specific technique, sometimes you can't tell that the patient has done Amani. You just see the bluish hues, and that's it. So it is really, you know, very rewarding for the patient and for the doctor in the next day. This is one of my patients who was referred by one of our retina colleagues. He had iris claw lens, a posterior one, and this patient had chronic uveitis and cystoid macular edema, and we decided to take this out and replace it with a Amani, and the patient was doing great on the first day.
Dr. Ahmed, sorry, I'm very sorry to tell you that the time is up. So otherwise, we are very enjoying what you are saying. But please summarize in 1 minute, please, if you don't mind.
I'll conclude in 1 minute. So we did, this is my data on 300 cases with an age range of 6 to 87 years, and the visual acuity improved significantly. Most of my cases were with the ZA 9003, and the indication ranged from subluxated IOL, Marfan patients, ACIOL with decompensated cornea, where we had the to replace the lens and do a DSEC later. And we use many techniques to check the IOL tilt, such as the UBM, the Chemiflag images, and my take-home message. So Yamani intrascleral haptic fixation is a very reliable technique for the IOL fixation in the absence of capsular support. The clinical judgment is very important. Every case is a unique case, and there is no single technique that fits all the cases. It depends largely on the surgeon's experience and on the situation of the patient. Thank you so much.
Great, thanks, Dr. Amal. It was a very nice presentation and very clear and comprehensive dealing with this technique, and congratulations for you. Now, the second speaker, we have a record for Professor Jorge Elio from Spain, and I think that the team will start the record for Professor Jorge Elio for Piggyback technique. Please start. Sound. We are not hearing the sound. Team. No, there is no sound. Please, saving the time.
Hello, my name is Jorge Alio, and I'm going to talk to you today a presentation about Piggyback intraocular lenses. These are my financial disclosures for the purpose of this presentation. I'm going to talk to you about Piggyback intraocular lenses in refractive surgery. The Piggyback was first described in 1993 by Gayton and Sanders and aims the implantation of a second intraocular lens, usually but not always in the posterior chamber, to adjust postoperative pseudophakic ametropia. An important drawback at the beginning of this technique was the development of intralenticular opacification, which appeared when both intraocular lenses were placed in the capsular bag in close contact of posterior and anterior surfaces, respectively. Adult lenses that today are manufactured by the industry are specifically designed, most of them, for implantation in the sulcus in front of a posterior chamber intraocular lens. The indications of Piggyback lenses are correction, especially of postoperative pseudophakic ametropia. Also, high refractive defects following corneal graft. Years after following cataract surgery in children. Postoperatively in eyes with silicone oil in the vitreous chamber that happens to have important variations in the refraction after silicone oil removal. And image magnification in eyes with age-related macular degeneration, as far as some lenses are low vision aids when placed intraocularly. Contraindications are those cases in which there is another lens in the sulcus, obviously, narrow angles, short eyes, shallow anterior chamber, pseudophakic patients with unstable capsular bag fixated intraocular lens, those patients with active ocular diseases, and corneal decompensation. There are important clinical features that happen to be necessary in a Piggyback lens. These lenses should be angled posteriorly to avoid iris robbing. They should have an adequate size to be stable at the sulcus. They should be posterior concave to adjust without contact in the posterior placed lens, and should have an adequate optic size. The main challenge of these lenses is its dependence on the internal dimensions and anatomy of the posterior chamber. Such anatomy cannot be still today precisely studied for the purpose of IOL sizing, even with the newest generation tools, except with very high frequency ultrasound, as you can see here in the image. The Piggyback calculation is relatively simple because most of the cases can be adjusted very precisely in negative refractions, multiplying by 1.2 the spherical equivalent to correct, and in hyperopic refraction, the spherical equivalent multiplied by 1.5 will give to you the target for emetropia. It is precise or not? Definitely it is less precise than examiner laser surgery in the post-op or refractive surprises following lens surgery. Astigmatic outcomes can be affected by corneal incisions size, as obviously could happen. Spherical outcomes are affected by effective lens position because the posterior lens can be displaced by the second lens. But it is less traumatic than IOL exchange surgery, and this is the reason why many surgeons prefer to do it. Here you have a paper that was published some years ago in which the refractive outcome of Piggyback lenses is demonstrated that is precise, but not more than LASIK or and better than IOL exchange. In other words, to use Piggyback lenses You have to be aware that you could do a better job with LASIK in terms of precision, but definitely you do a better job that in performing an IOL exchange, because the resource involved in the traumatic and astigmatic induction that can happen when you are implanting a lens instead of implanting a second lens on top of the previous one. This is another paper in which it is demonstrated that astigmatic induction of piggyback lenses happen because of the incision, even that the correction of the spherical error is adequate, even that, as mentioned before, not as precise as with standard laser surgery. Piggyback lenses have different models available. You can use a conventional lens like the Alcon MA60 or MN60 or similar to be implanted in the sulcus. As they have a low power, they are thin and they fit well for the purpose. Some lenses have been specifically designed to be piggyback-like, and they could be diffractive, refractive, and some lenses are targeting at the magnification of the image when reading and are used as low vision aids. IOLs are used for bigger purposes today, also as far as they fit well as the Artisan family, especially the Artiflex, but also the Artisan in toric corrections and the ICL as well. Add-on lenses have a specific brand, which is the first Q. This is a lens that is created specifically for the sulcus. It's a hydrophilic acrylic lens. The overall length is 13 millimeters. The optical size is 6 millimeters and is convex concave to be away from the already implanted lens. The haptics are rhomboidal, and the incision that's required is about 2.5 and could be down to 2.2 if you use corneal tunnel incision technique. These lenses are created as toric, spherical, and they can be also multifocal diffractive. Sulcuflex has another lens from Reiner of acrylic hydrophilic material. The overall length is 14 millimeters, the optical size is 6.5, also convex concave. The haptics have a posterior angulation to avoid contact with the iris, but the incision is large, and this lens needs to be implanted 2.8 millimeters. The outcomes are good as reported and seen in this paper. Multifocal piggyback lenses are an opportunity to create a multifocality in already pseudophakic monofocal eyes. Different models have been proposed. The first one to appear was the Alcon Restored, not available today as a sulcus model. The size trifocal is offered as a sulcus implantation. The Oculentis M Plus has a specific lens designed for the purpose, and the multifocal Sulcuflex as mentioned before. The main problem of all these lenses is that they require a perfect alignment of both lenses concerning the optical axis, and if this is not accomplished, then loss of best corrected visual acuity lines and dysphotopsia happens frequently. This is an important drawback of multifocal lenses alineation. This multifocality, anyhow, is reversible, and this is the reason why some authors have proposed, just to avoid promising neuroadaptation and to have a second chance to patients implanted with a multifocal lens, to implant all of them with a monofocal lens, and then on top of them, of the previous lens, a multifocal lens implanted at the moment. If this is successful, then the lens is left. If this is unsuccessful, then the lens is explanted, and you follow with the second eye just with a monofocal. Even that this paper that is referred in this slide proves that this is a safe technique. Indeed, it's not used by many surgeons because it involves a secondary surgery, and indeed is less accurate than to have just a straightforward multifocal lens, in spite of the very few cases in which fail of the neuroadaptation could happen. In the long term, you have these lenses that are implanted as secondary in the sulcus, with a previously on purpose placed monofocal lens are stable. And in this paper that has been mentioned before, when two groups were compared, the use of a single multifocal lens or a monofocal plus a piggyback lens was demonstrated to achieve the similar outcome, and no difference were observed between the two groups. This study indeed was similar in both groups in terms of contact sensitivity, uncorrected for distance, visual acuity, near vision, and complications. Other contraindications have been mentioned, and you have to remember one that is very important. You have to consider that patients with any ocular condition which the final vision will be less than 0.6 are not a good indication, because multifocality requires good visual potential, and those patients with not adequate and high visual potential will not fit well with a multifocal lens. You have different papers here demonstrating that the use of add-on multifocal lenses is successful, and I can tell you that in my hands, this technique works well with some models like the Sulcuflex. Add-on lenses can be used also as low vision aids. This model is made by add-on company as well, and the material hydrophilic acrylic with an overall length of 30 millimeters. There is a central portion 1.5 millimeters with a +10, which makes a high magnification to read, and the haptics are 4 symmetrical haptics. It requires an incision of 2.2 millimeters. Definitely this lens that was created by Sariot works well, even that requires exquisite centration, and is only useful for those patients that have a residual visual error that is adequate. One important thing is that Sariot indicates this lens in the best eye of the patients, in which ocular degeneration is lowering the visual potential to a level that makes the patient not possible to read. Piggyback with fake lenses is another possibility, and is very successful. You can use the Artisan lens family, either the Artisan or Artiflex, or the ICL Star. The Collamer lens, the ICL, in the management of residual ametropia works well. This lens obviously is designed for the sulcus, and you have to use to calculate the same parameters that you use for the phakic model in phakic eyes. The use of toric models, positive and negative spheres, is successful, and is one possibility that is really useful as far as the lens is very thin and requires little manipulation to be implanted in the sulcus. In conclusion, add-on piggyback lenses are an effective solution for large pseudophakic residual refractive errors, are the only available surgical also to reverse multifocality in case that you have a doubtful case in which you don't want to implant a lens straightforward, but rather to have the chance to remove it and to leave it at the patient with a monofocal lens implanted at the same time. There requires a perfect alignment between both intraocular lenses, which is the main challenge of this technique. And remember, lenses that are preliminarily in the back but not perfectly centered will not be a good indication, because these lenses will not be in centered and aligned with the piggyback lens. And indeed, the use of piggyback lenses, even that is successful, has a slight lower patient satisfaction than compared with primary implantation. Scientific evidence is still not that abundant. We have to remember that this alternative to use monofocal and multifocal lens on top as a purpose has only 2 papers published, that even that report successful outcomes needs confirmation. Obvious indications are, again, let me summarize with this message. Patients with monofocal lenses in the back and who have a strong wish for multifocality and a properly centered lens. Purple multifocal implantation is in the limit of indication, because you have early macular disease, moderate amblyopia, or extreme ametropias could be also implanted with a monofocal, and in the same time with a multifocal that could be removed later. And absolute contraindications indeed is any case with corneal pathology and irregular corneas. In summary, piggyback lenses are a good solution for postoperative refractive surprises. They are also a good solution for refractive surprises following corneal graft surgery. Not as precise as examined laser surgery in virgin corneas. They are safe in adequate selected patients and adequate intraocular lens properly chosen. Phakic lenses, especially the RT lens group and ICL, are also very good alternatives. A sulcus-to-sulcus calculation and sizing is still the main limitation for the astigmatic correction and the use of piggyback lenses. I want to remember you that we have this online course on refractive corneal lens surgery in our university with over 500 hours of multimedia activities in English, which is excellent for those junior ophthalmologists who want to enter this exciting area of refractive corneal lens surgery.
Great, thanks, Dr.
And I thank you very much for your very kind attention and your invitation at the Quasimi Ophthalmological International Conference. Thank you very much from Alicante, Spain.
Cut the record, please. So moving, because we are over the time, at least 4 minutes. So we will move to the next speaker. That will be me. I'm Dr. Safwan Bayati, consultant ophthalmologist from Dubai, and I will take the please disconnect the share of Professor Khalqi and allow me to share. Organizer, please.
Yes, you can now, sir.
Be with us, please, if you don't mind. So we will go through and we will take the Amani technique versus the flunged fixation to another issues. First, what I said that let's Dr. Amal, I know that she is the most expert, so I put her in front of me to defend my side from any issues. And what I will do is that I will discuss the modified issues in Yamani, comparing to a double flunged. That's what I'm doing both. So sorry, I will start the sharing. As Amal said that we need a special equipment for that. So preparing those equipment, I think that we missed something. Yeah. Yes, the important issues that Amal mentioned, few things related to the lenses. What's present here is the sensor. What I like, addition to the PMMA, I'm not using the PMMA. And Amal mentioned things related to the haptics, that polyvinylidene fluoride. That's what I like because it will prevent some complication intraocular for the PMMA because the cracking of the PMMA. For the Lucia, that which is not present there, why we are mentioning, because the needle that we will use, the gauge 23 is for the Lucia, and I'm using 27 for the sensor. Because sensor and PMMA, we need 27, so 27, it's much better, easier for me for the sensor, the lens that I'm using. We need two important tools, the microforceps. The microforceps that we are using is gauge 23, and ink and caliper and the cautery. And as Amal said precisely, that the cautery should not be the cautery that can be, it's a moderate in a way that the heat and the tip of it will not eat around. If it is very hot, it's a red cautery, it will take around 2 millimeters from the haptics, and that definitely will give us a disaster during the implantation. So it should be cold in a way that the flange will be only able to stuck in the scleral tunnel. And then she said something, Amal, I will compare to the Amal because that's what we are doing. This is the aim. The anterior AC maintainer and the trocar. Me, I prefer the trocar because what I learned from my experience, from this long experience with the Amani and double flange, is that when we are holding the trocar, I'm using it for the infusion cannula and for a holding. I'm using the trocar to hold it and go through the tunnel, because the tunnel is a very crucial issue to create it. The simuli, she mentioned issues that related, that it's one of the important issues for the teaching for the newly used or those using this technique in a beginning or a beginners. And I will show you a movie that shows this using the Amani technique on the simuli. As we know that the marker is an important, and we will repeat, I'm repeating that the marker is important, 2 millimeter by 2 millimeter on counteract on to each other. The rights counteract the left. And this simule is very easy to use in a way that you can teach yourself, whether in a usual technique or in a modified technique. Now I'm showing the first needle that it will stay in. I'm bending it 9 millimeter, not 11 millimeter, in a way that it will kept, because I'm keeping these needles in, and I'm using the trailer haptics to be fixed first, and then the leading haptics. The second needle that will be externalized, the leading haptics, it will be bent on 11, and the beveled, you can see that the beveled is facing the surgeon, the face of the surgeon or the tools of the surgeon. This is the lens where we implant. Definitely sensor or any lens with haptics of polyvinyl DIN, it's very critical to implant it in a right way. And all the implanting injectors, it's screw. There is no one, or you can use one hand in injecting. So I'm testing the whole lens before doing any lens that I'm using, testing the haptics with the needle to see whether it's easy to use, and I'm using the tip perpendicular on the beveled and then passing it, so it will be easy to pass. This technique and these tricks is very important for a beginner to use, and then inject, and then using it inside. The leading haptics should be straight, and the trailer haptic should be clear, that it will go through, because that's very important in the modified technique. Now, in the modified technique, this paracentesis should be done at 6 o'clock to externalize the leading haptics. And I'm testing these paracentesis in a way that it will be easy to handle the microforceps in it. And now, holding the tip, externalizing it outside, so I'm not in need for iris support. Here, the two haptics is outside, so the support will be for two haptics. I feel more support, more secure to be. Now, the paracentesis, it should be the right and left. The right should be toward the leading haptics, and the left, it should be toward the right side, the left paracentesis toward the left, the right side, where I will externalize the trailer haptics. And the trailer haptics will be externalized first. So now I'm doing the tunnel and passing it. Here, it's very easy now to handle, because we have the leading haptic is supported. I will return it back to the AC, and then through it, going through and pass it to the, as I said, perpendicular to the beveled. Beveled should face the surgeon, perpendicular to it, and then external. Here, I will keep it in, and then going to the second tunnel and try to externalize the second haptics. And take it and put it in, and in this way, we externalize both. We will cauterize here there will be some tension on the right haptics, on the trailer haptics, but it's movable, easy to move. So this tension, that when you are fixating the leading haptics, it will be easy, and the centration is fixed and fit. The second is the real surgery. Here I will try to be accelerating the movie as much as I can. The haptics is the marker is the same, going through and needling, preparing my needles, and then the paracentesis at the 6 and paracentesis at an addition to the 2 paracentesis, methyl cellulose, cohesive, distorted dispersive, and then testing the microforceps, holding the trocar, creating the tunnel, and then the lens, and externalizing the haptics out. Here it's been changed. It doesn't matter. The haptics is so elastic in a way that we can handle it in any way. It will not crack. I just showed that point in a way that it shows clearly that the PMMA here, it will crack, and from the angle as Dr. Amal shows. Now, the trailer haptics first, going through my angulation for the forceps, it makes the tip of the haptics perpendicular to the bubble, and then in, keeping the lens, keeping the needle in, and externalizing and creating the next tunnel, and then entering and try to attract the haptics, keeping it in, easy to get it, and put it, because this step is easier than the trailer haptics. And then cauterizing it and centering the lens. Now, this is the second day pupil. Now, here in this surgery, it's a half surgery where half of it's done by double flange, and the second half I just showed to you because it will be done by double flange. This lens is 4 eyelets, where I did the left side by double flange and the right side by also it will be done by the double flange. You can see instead of 2 marker means that 2 millimeter from the limbus, and then 2 millimeter away on the on 2 other sides, in a way that we will fix a loop around the 2 eyelets. So it will be shown here in this movie. It's a very quick movie. Here I'm preparing the needles, and I will use 5-0 polypropylene. Here I'm testing the suture. I can show the paracentesis. Centering the lens, the first loop, so the first tunnel, passing the suture 5-0 in, externalizing it outside from the first tunnel, holding it, flanged it, I'm cauterizing the tip of it, then using the other end of the same suture, flange it, cauterizing it, it's flanged, that's all. So now the second haptics through the other eyelets. There's 2 eyelets in the tip of the lens. In a tunnel which is opposite to that tunnel, and then in, and it will go through the second eyelets, and then looping the 5-0, holding it by 2 micro forceps, passing it through this is gauge 26, externalizing it outside. This will make a loop around the 2 eyelets, and then here I'm pulling because there is 1 flange done already. See, pulled. Now the first flange has been barred, and then the second flange will be cut and barred also, and the surgery will be ends here. I'm searching, and the center, the lens is in the center. Sorry to make you late, and I think that this will take more discussion later. So we will go now to a second speaker, Dr. Yasin Dawood. I'm sorry that to make you Yasin waiting. So I'm stopping the share. Dr. Yasin. Yes, Dr. Yasin.
Good evening. Thank you so much. I really appreciate the opportunity. These are fantastic. And I'm really, really glad that we are actually following each other, because the points that you and Dr. Amal basically will put a lot of perspective on the mishaps that we have. So you guys really are pioneers in these techniques. And I really liked yours with the 4 flange IOL. I think it's the 4 eyelet IOL. I think it's a fantastic technique. I've used it in the single piece IOLs. It doesn't work as well. So probably the 4 will work much better.
We need 4. Yes,
yeah,
exactly.
But the single, don't try it. As they say, and this is what this video is probably going to show you, experience is what you get when you get what you don't want. So as I have done, I haven't done as much as Dr. Amal, but I've done at least a couple hundred. I want to actually pause this. So this video is I'm teaching my fellow how to do it. She's a fantastic surgeon. She's a great surgeon, but she's starting this technique new. And she's done actually a couple so far with me. And I'm like, okay, well, let's do this. Except the fact that I actually make a quick mistake and I do not pay attention to. Number one, before I start the video, I usually use a Mendes marker, and I really center it right on my cornea. That way I know exactly that I am 180 degrees. Whatever mechanism that you use for 180 degrees, as long as it is, and it has to be bisecting your pupil. The problem is if the eye is dilated, the bisecting of the pupil may be a little bit off. So really getting what we call external landmarks is better than getting internal landmarks. So in my hands, the Mendes marker works very well. And I just, here it is. All of our, this is actually a new caliber that we got into our OR. We normally have calipers that are actually 1 steps rather than half a step. And that will show you what the problems that we're going to have. So here we are marking, we're like, oh, this is great, we're marking. And I'm like, wait a second, this looks a little bit, you know, I go like 2 millimeters on each side, but this looks a little bit not too far as much as, and then I don't pay attention to it again, as if like divine guidance is happening here. And it's like, here is what's happening. So this is actually a half, this is a 1 millimeter. And our caliber is usually, this is 1, this is 2, this is a 3. So all of a sudden you change your vendor and you are completely in a different area. So of course that's going to help us lead to problems in the future. And instead of me, the attending, being very attentive to this, I'm attentive to her technique, but not the measurements. She does a beautiful job at going in, but you can see she's tugging actually a little bit on the iris again, because we are too anterior. Not much happening, but I'm like, okay, that's weird. I actually like to go, you know, with this right around 140, because as I am dialing in, I actually am able to do this almost without fail with a thin-walled needle. And once I do this, I'm like, okay, now you start having to grab it. And what you want to do is the needle has to start coming back again the way it is. She's stopping because she's waiting for me to dial the lens in, which is fine. But at least I have one anchor. I agree with the panelists. You should always have the other haptic, either the leading or the trailing, or both of them out at one time in case it falls. And now, so she comes out, which is fine. She's holding it beautifully. What she has done is beautiful. We do use actually a hot tip cautery, but I keep it a little bit far. And so far we have not had problems. I do like the tip with the you know, cold cautery, but the hot tip, we haven't really had much issues. I think the PVDF does fine. And now I'm like, wait a second, you know, show me back that caliber, something just hit. And I'm like, oh my gosh, now that we have finished that, you know, the leading haptic, that there's a problem. So how do I externalize it? Well, one thing you could do is you could actually get a microforceps and rotate the lens back into your insertion sclerotomy site. And if you are lucky, you will get the conjunctival space that you were in. So let's see if we are lucky. And sure enough, we try to kind of find it, and it actually comes out. That's wonderful. So that's the first mistake. By the way, there are like about 5 mistakes in the surgery, so bear with me. So I cut.
Okay, so just Dr. Yassin, wait here 1 minute. That's why I'm keeping the needle in, and because for this reason, that when I need to rotate or I need to manipulate, the needle is in and the haptics is in the needle, so the mobility is very easy. Now you are lucky here, but it might be stuck in the sclera tunnel. You cannot rotate.
I'll show you. Be patient with me, Dr. Safwan. It gets better.
Okay,
not only that, I have had another fellow who put the needle, and then as he's moving, the needle actually went in the retina, and we had a retinal tear. So there are problems when you have 2 needles. I've seen quite a bit of these things. So now I actually say, oh, let's get the measurements right. Of course, remember that we actually cut this, and now we are dialing it back in. So this is actually still the fellow doing the surgery. I'm like, I think I have belief in her and trust in her and faith in her. But the problem is now, I'm like, okay, I think she's actually putting it into the needle, and it looks like she's moving the microforceps. So it's feeding. And let's see what happens when she tries to externalize it. So these are the things that you really need to think about. Is this going in? Is it not going in? Look how long the haptic is. This is not in the needle. And watch what happens. Oh, there's no haptic. Now, why is that happening? Why did the haptic not go into the needle in the meantime, the first time it did? This is probably the most embarrassing public video that I have put. So you look at it, I'm like, no, show me in the center, and it doesn't fit. How the heck did it fit the first time, but it didn't? Remember, yes, it's a thin-walled needle. Remember, it was fine, but you cut it. And when you cut it, actually, you flatten it so it stops. That's the whole point. You created a small flange, actually. So we
Yes.
rotate it to the other haptic that has not been worked on. And we say, okay, well, let's get this in now.
What's the
So
size of the
number-
needle?
Sorry?
What's the size of the needle?
The needle is thin walled. It's about 0.18. So it's a thin walled needle. It's the TSK needle. So
Oh, okay.
now watch this. You see that flange right before I did? So here we go. You see how it's a little bit thicker than the
Exactly.
rest of the PVDF. So now
Yeah.
what you have to do is you actually have to cut it at an angle to make a bevel. If you actually cut it sideways, like just perpendicular to it, you are going to get it a little bit thicker. So actually, you'll see me that I am cutting it just as a bevel. Now I want to make sure it fits, which is what Dr. Safwan told us shortly before. And now I am actually doing the surgery. So I basically fit it. And I'm like, I don't want this to go out. This is too aggressive. This is too much. You do not need that much haptic. And then you start basically rotating it. I'm doing this actually under viscoelastic material. Usually you can use AC maintainer or viscoelastic material. And here I'm like, that's great. That's wonderful. But there's a problem. The lens is decentered.
Yeah.
So now I have to go. And here is what happens. If you do a small peritomy, generally you should be able to find the lens with a little bit more pushing. And then basically all of a sudden, after all of this and about 10 more gray hairs in the world, the patient does well and the lens is fine. And actually, this is as of 10:36 a.m. I just saw the patient 3 hours. We're American time, and the patient is 20/30 plus 2 uncorrected. And this is actually was ectopia lentis case. I did not show you the cataract part. So patients still do really well. Here's the bulb in case you're wondering. They do very, very well, but nonetheless, these things can be avoidable if you know what you are working with. Let's have a discussion, and I'm happy to take questions.
Okay, so you finished. No,
I have the pearls, but you guys have gone through the pearls already, so I don't feel that I need to do it.
So the first question that we need, because Nancy, I don't know that whether she will be lucky to join us or not. Nancy Raqad, unfortunately, our colleague Nancy Raqad, till now she didn't join us. So I think that we will move to the discussion. And the first question is that what's the target of the refractive error that you will put when you are calculate, Dr. Amal, the calculation for the IOL for this kind of technique?
Yeah, so in the beginning, I used to do a -1, but now I do minus 0.5. And
yes, exactly.
The visual outcome is good and corrected.
Exactly. So, and Dr. Yassin?
The same. I think initially we were all aiming a little bit more myopic because we thought that the effective lens position is actually more posterior. But now that we have looked at our data and we know what the spherical equivalent, we are about like -0.5 to -0.75. Now you have to, one pearl that I was talking about that I think we haven't mentioned is the fact that, the needles 180 degrees apart, 2.5 millimeter is what I usually use actually. It depends whether the patient is high myope or whatnot. So this is not one size fits all. You have to really take the eye into consideration, but that's a good starting point.
So in myopia, in myopia, what I'm targeting is 0.5 or 0.25. In hyperopia, well, I'm targeting if the tips it will be cauterized without cut, then I'm still targeting 0.75 to 1, because in myopia, like for example, those patients that they have, for example, -3 or -4, once you will target minus, and because you need more stretch and more haptics length, then you will end up with more minus. So I'm reducing the power of the target power in a way that I can reach to ±0.25. That's the target that I need. Now, regarding the double flange, which I start to do it more than Yamani, because now I'm depending on the availability of the lens. Whether we have Physiol for I'm using Physiol for eyelets or sensor. So whatever available as a power, I'm going through, because both of them I'm doing as a technique. And I found that when you are doing the double flange or four flanged, it's it's easier, short surgery, and you don't need that all skills to go through and do these issues related to Amani. And the crack or bent, because in polyvinyl fluoride, what's happened is that when the haptics is bent, or it will not crack, but it will kept bent, so it will affect the tilting of the lens, which not happens, but sometimes it might happen. So that's why I'm taking care that 4-flanged is more easier, but it need 4 eyelet, as Dr. Yassin said, because the stability of 4 eyelets creating the loop around these 2 eyelets on both sides is very easy, but you need the lens to be available. I think that we spend a very, very interesting time, and hopefully that anyone can have any question for us. And I'm not seeing that there is a lot of questions coming.
So another thing that I do, I noticed that Dr. Safwan, you use 5-O-proline. I use the 6-O-proline and it works perfect. And
Yes.
you can actually use the 6-O-proline with the TSK needle, which gives you a little bit also smaller, sclerotomy or a scleral tunnel size. And then you can have a little bit smaller flange as well. So that's another thing that you can use if you have it available.
Yeah, it's available. I'm using sometimes according to the availability 5 or 6 and changing the needles from 27 to 26 according, because I'm testing the suture entrance before and I'm testing the haptics before. So accordingly, I'm using it according to the resistance that I feel. I'm using the needles. Dr. Amel, any question?
Yeah, actually, I have a question for both of you about the iris capture. So I did not have this issue a lot, but we had a patient that was, a great headache. It was done by one of my colleagues. The axial length is okay within, I think, 23, but he had a very deep AC, and every time the pupil dilates, then the iris would pop in the AC, and we did not know what to do for this patient. So what do you do?
You mean the lens will pop up in the AC?
There's an optic capture.
Optic capture. Yeah.
So that's a great question, actually. Do you guys have access to an anterior segment OCT or a UVM?
For sure.
Because many times you could have like an Otz-Devalia syndrome or something if the iris itself is actually bowing down. I have had a case of my own. And it drove me nuts. I'm like, the lens looks beautiful. The markings, I measured them 3 times in the clinic again. And I'm like, what is going on? Why is it happening? And the patient came in with, a little bit of a UGH even sometimes.
Yes.
And I'm like, and then what was happening is the iris was actually the culprit. It was bowing back rather than the lens being actually too anterior. I do have pictures and I could show it in another meeting, hopefully. And in those cases, there are a couple of things that you could do. And if you have time, I probably could pull the video. One thing is, if you actually do 4-throw pupilloplasty on the pupil to actually bunch it up a little bit, that will get the iris away from the lens. Another thing is, what I did was I used the 6-O-proline with a 27 gauge needle across, and I did a basket suture to push the lens back. And basically the 2 6-O-prolines, it's 1 6-O-proline, but the 2 ends of it are going to come across the IOL, right almost at the pupillary edge or back, and that will pull it back. The third thing is you could do a little bit of a PI2 or keep the patient a little bit constricted with like alpha-GAN or brimonidine is what we have, or a little bit of pylo, diluted pylo or something. There are a lot of things you can do as long as you are sure that the lens itself is not tilted. If the lens itself, you have to figure out, is it the lens or is it the iris? If it is the lens, then you should really look at the lens and scaffold it one way or the other. If it is the iris, then you can suture the iris a little bit away.
Okay. And we don't have enough data to support. I was thinking in such a case, like if I entered more than 2.5 millimeter behind the sclera, would it make a difference? I don't know, but we're thinking about doing the suture and keeping the lens behind.
I think that you need, because how you know that this will happen? So to go to 2.5, you need to change the calculation.
It's not easy sometimes to guess which patient will have
that's what I'm saying. So when you have it, and then you need to, when you're expecting that this patient will have it, then you can go and changing the calculation. Professor Kholkhi, is there any question from your side to our procedures? You are muting the sound. There is no, we are not hearing you.
No, thank you. I think that I am happy to listen to your presentations. They're very, very neat. And the issue is that I seldomly use these techniques, because for us, to implant a retropupillar artisan is 5 minutes surgery and the case is finished. And this is a vitrectomy. It's a cost effectiveness is negative because you have many times 2 surgeons to operate the vitreous. Then you have the complications that can happen. We know that there is no freelance in this technique, even that is very neat and very sensitive. But with the retropupillar lenses, we have excellent outcomes, and believe me, we seldomly have any complications. So this is for me a simplification of the problem. Obviously, you cannot use this technique or retropupillar artisan if you have a very abnormal iris or you have a traumatized eye with an iris coloboma. And then is when we use these techniques that at this moment I still prefer the suturing, the suturing because it's more straightforward, save a lot of time. You don't need, again, a vitrectomy, a 3-port. I think that we are, and it's my opinion, I can be wrong, overestimating the need of these techniques, making things that are simple, very complicated. This is my personal approach, with all my respect to the speakers who have made a wonderful job. But I think the debate is there. Well, how much is what you need? How much do you need? How much do patient you need? Imagine a patient in the 80s with a drop lens or with a phakia that has suffered complications. To go through these surgeries, in my opinion, inadequate. A sulcus suture lens will do well, even with Prolene. The Prolene will not disintegrate in a 80 years guy unless becomes 120. And if you are a retropupillar artisan, you have a 5-minute surgery and the patient is going to be as happy as that. So this is why I think that this is the art of indicating the surgery. It's in hands of good surgeon, does very well, but not everybody is like Dr. Daoud and Dr. Al-Wikat, and some of them have complications, and this is my point, okay?
So actually, Dr. Jorge brings a beautiful point, and that is there's always a new kid on the block. And the question is it a whole lot better than what we have or not? And I think that comes with being a seasoned surgeon. I agree with you that basically the AAO came up in 2003 and they compared, scleral versus iris versus ACIOLs. They showed no difference. And then we said, wait. But now we have glued IOLs, we have iris fixated, claws, and we have iris suturing. Is that a lot better, or the ACIOL? And guess what? It showed also no difference. So it's not one size fit all. And I think it's what works in the hand of the surgeon and within the circumstances. If you don't have special lenses, if you don't have special instruments, this may not be the best technique for you. But when you actually look at the outcome of all of the different fixation techniques, and I personally, on Monday, I will be doing like all 4 of them based on whatever patient I have. There's no difference. And I can actually tell you, I had a patient, this is like 6 months ago, I put iris sutured IOL in one eye and I put a Amani in the other eye, and he likes the iris sutured IOL versus we thought that, because the iris is a little bit hypermobile, so the vision quality is not going to be that good. And this is a very high functioning guy. And he's like, no, I love the vision in my right eye. My left is not as good. So I think the truth is we don't know as much as we think we do. And there's always a newer technique that will come up, but it's a pretty decent technique at this point.
So as you said, the availability of the material. Sorry, sir. Please.
No, it was just a remark. The comprehensive lens surgeon should dominate these techniques because it is patient-to-patient indication, as Dr. Daoud has mentioned. I totally agree. And you have to use the right instrument in the right patient in the benefit of the outcome. The final is what matters, and the benefit of the patient. Thank you.
So as I said, that according to the availability of the power of the lens that we need, because sometimes when you are doing the surgery and you are facing such a problem, not in planned way that when you have a referral cases, you can plan, you can prepare your lenses, you can prepare your issues according to your experience. No, we are talking about things that you are facing it intraoperatively and you need to. So I'm preparing everything, but sometimes it's not available as a power for the distributor. Yeah, and you need the power, and it's not available for sensor, for example. So I'm using physio for flange. Or in contrast, we don't have physio, so I'm using the sensor, and so on. In any way, as you said, all said, that the experience of the surgeons, availability of the material, availability of the lenses can guide the surgeons to the best, but most of them, they are doing well, and according to our experience and skills that we gain, that we can do this surgery. So I need to finish this session because we run the time. Sorry, Yassine. But it was a nice, lovely. So I'm grateful for Dr. Amal and Dr. Yassine and Professor Jorge. He's our master, and a nice time that we spend, and hopefully that we will see you again in other meetings. And we need to say great thanks for all the team and speakers, and for the team from Quick, and for the audience, and great thanks, and have a nice night. Thank you very much for all.
Thank you so much. Bye, my friends. Bye.
Absolutely. Good to see you, Jorge.
Bye.
Bye. Bye. Bye. Good seeing you as always.